Okay, looks like we're good to start.
Are we going live now? Good afternoon, everybody, and welcome to Kirklees' Health and Wellbeing Board, held here on the 4th of June 2020, and this is a virtual meeting. Welcome everybody who has joined us. Could I ask that if you have any queries or questions or wish to make a comment, that you use the chat system down the side of the screen, please. Jenny, have we any member apologies for the meeting?
Yes, Chair, we've got Carol McKenna and Councillor Carol Patterson.
Thank you. And Phil, could you go through a list of who is attending the meeting today, and also if anybody is substituting for someone else, please?
Okay, I shall attempt it, but if I do miss anybody, please let me know. So obviously we've got Councillor Kendrick in the chair, Councillor Kath Pinnock. We've got Ian Currell, who's substituting for Carol McKenna from the CCGs, Richard Parry from the council, Rachel Spencer Henschel, and Emily Parry Harris. Helen Hunter from Healthwatch Kirklees. From Locala, there's Karen Jackson, Jane Close, and Diane Kerriger, who's just joined us. Catherine Giles from NHS England sent her apologies, but Neil Coulter is attending in her place. There's Anna Basford from Calderdale Huddersfield Foundation Trust, who's substituting for Owen Williams. Matt England from Mid Yorkshire Hospitals Trust, who's substituting for Martin Barclay. Tim Breeden from Swift, who's substituting for Rob Webster. Val Johnson from Third Sector Leaders. Ian Holmes from the West Yorkshire and Harrogate Health and Care Partnership. And Councillor Zaman, who's the Chair of Scrutiny. I think I've got everybody. Please do let me know if I've missed anybody.
Okay. Thank you very much. So welcome everybody who's here today. Found somebody else.
Apologies, Councillor Khan had a connection problem, so I've just seen that she's also in attendance.
Okay, all right, welcome. So if we could move on then please to the minutes of the previous meeting. You should have all had the documents. As much as anything it is, if you could indicate in the chat column if you think there are any corrections. I haven't seen anything, but somebody else may have feel that there's something that needs amending or adding to. No? And therefore, can I ask that we accept these as a true copy of the previous minutes, please? If nobody's shouting in loud protests, I'm taking that as a yes. Thank you. So interest, people are asked to declare interest. If anybody does have an interest in any item on the agenda, would you please let the governance officer, Jenny Bryce Chan, know that, please? This meeting, all the items at this meeting are held in public and are available for anyone to watch this webcast. Jenny, have we any deputations or petitions, please?
None received.
Thank you. So agenda item 6, questions from members of the public and or councillors. Have we any questions, please, Jenny?
Yes, we've received one question from Councillor Zaman, and it as follows. What is the current process for testing of hospital patients for COVID-19, and what can the 2 acute trusts, CHFT and Mid Yorkshire, do more to inform and reassure members of the public about testing for COVID-19 prior to discharge? If you're not sure, I can read that again, if you need that again.
No, I think that was quite clear, thank you. Okay. So we've got Matt England and Anna Basford here. Are one of you going to do a response on behalf of your trust first?
Councillor Kendrick,
yes.
We did think that these might be matters that could be picked up in the contributions both Anna and Matt are going to make during the presentations, as they are included in that.
Right.
So
Okay.
perhaps if we hear the presentations, and if there's still any outstanding issues, we can deal with that in the discussion following the presentation.
Okay. All right. Thank you very much. So
can I just add one more thing, because I've just been double checking attendance, and there's a couple of people have joined us.
Yeah.
So Mel Meggs is in attendance from the Director of Children's Services, Councillor Thompson, and Dr. Naeem from North Kirklees CCG, and Dr. Steve Ollerton from Great Huddersfield CCG.
Indeed. Welcome all of you. So the main item of the agenda today is agenda item 7 about the implications of COVID-19 for Kirklees. We did ask all our partner organisations, and including services within the authority, to talk about what they've been doing, what issues they've been addressing, what the situation is, and what the next steps are, if you like. That's what we're asking people to cover. I understand we've got some slides to present, and the first person who's going to address this is Rachel Spencer-Hensel. Rachel, over to you.
Thank you very much, Chair. Okay, so I understand that the slides are going to be projected, which they are doing now, which is great. Okay, so what I'm just going to present in a few slides is just a bit of a picture of how COVID has impacted Kirklees. These are population level data, so obviously it doesn't go into quite a lot of detail in terms of which communities have been disproportionately affected, and I'll pick up that point at the end. So at the moment, we've got 657 confirmed cases of COVID in Kirklees. You can see from that graph where we had a steady increase, and then that's levelling off now. Next slide, please. Okay, this just presents the data to look at 7-day rolling averages, and again, you can see where that peak shot up and then how it's reduced. If you can see towards the end there, around this kind of end of May, you can see that there's a slight increase again, which reflects the push on testing that we've obviously been done nationally and been putting in place here. So we've got more tests happening. Next slide, please. This is a graph that's from the Office of National Statistics, which shows the all age, all cause mortality up to the end of May. As you can see, and I'm sorry, they are quite tiny slides, but you can see where the lockdown started, where school closures, etc. And then you see the increase in excess deaths that we've seen following that. If you look towards the end of the graph, we're still higher than we would expect to be. Next slide, please. This slide just shows you kind of how the COVID deaths relate to the deaths overall. So we had 90 deaths at the 22nd of May, and of those, 8 were related to COVID. You'll be able to see where we hit our peak, which you can see from the highest point of the blue graph and the highest point of the yellow graph, where we had on average about 150 excess deaths, of which 50 had COVID on the death certificate. Next slide, please. This graph just shows you where the location of the people who sadly died were at the time. So you can see that the green line is hospitals and the blue line is care homes. So it's interesting to see where that peak shifted. So it obviously peaked in the hospitals first and then moved further on into the care homes after that. Next slide, please. Just my final slide, and I think this is an important one. If you look at the pale blue colour on the graph at the top, you can see that even though our excess deaths from all causes are reducing, they are still higher than we would expect to see in this 5-year period. So it's quite important to remember that even though it's probably from the previous graph at a similar level before lockdown, it's actually still higher than we would expect at this time of year. So obviously the important thing is to understand what the differential with that is, and it links to the campaign that we've been working on with our CCG and NHS colleagues about ensuring people who seek medical advice for anything that they normally would, and push that message that the NHS is still open in that case. Okay, that's those slides for me, so I'm happy to take questions, Chair.
I think we were going to aim at, although I do know there's one that's perhaps relevant to one of the slides. We were going to do the questions at the end, but when somebody's querying some of the information on the slide, it's perhaps, I don't know, Phil, worth it doing it while we're near that slide, really.
I think as long as we can keep moving quite quickly, otherwise the risk is we
end up
we
here
lose
at
time for the
midnight.
discussion at the end.
Yeah. So are you saying that we address this issue? Certainly Dr. Ollerton's put in.
I just wanted to know what date the peak was, because your text was very small. That was all, very quick.
Yeah, and I think Dr. Naeem has said it.
Has answered it.
Yeah. Which is as best guess we can make, but it was certainly that week between the 10th and the 18th.
Okay, thank you.
So who's next? Is it Phil?
Apologies. Helen from Healthwatch is going to.
Thank you.
Hi, so just wanted to provide a little bit of feedback from what we've heard so far from members of the public who've been talking to us about their experience during the COVID-19 period. I've split it down into two slides, one which sort of explains the really good stuff that we've heard, and the other slide which focuses on the kind of concerns and problems that people have raised. What I think is really important for me to reflect back is that actually we are hearing lots of good positive feedback from people living in Kirklees, and because often we can get really caught up in hearing sort of the problems and the concerns. So there has been a lot of really good stuff that people have talked to us about. In terms of what I've got on the slides here, generally speaking, we were seeing an improving picture in terms of the feedback that we were hearing about health and care services. Initially, there was quite a lot of concerns being raised about the teething problems that were happening as people tried to work in a new way, and a lot of that's been resolved now. But I think we're starting to hear some of that stuff again as things are being reintroduced and people are kind of reattending places that they've been before. Almost all of the good feedback that we hear involves an element that relates to clear communication. So where people have difficulties, it's because they don't have that clear understanding of what they should have been doing, where the service would be available to them. So clear communication is something that's been really highly prized by people who've talked to us. There's been lots of good feedback about adaptations in primary care, and certainly requests from the people that we have spoken to thus far that things do not return to how they were before COVID-19. Lots of people who have spoken positively about the fact that it's been helpful to have telephone and video appointments, but actually to still be able to see a clinician if that's needed. And I think that's been received really positively by the people we've spoken to. There's been a lot of praise for staff working in the hospitals, lots of praise around the compassion for people who were at the end of their lives, and loads of gratitude to people in the community as well who've stepped up and supported their neighbours, got involved with different mutual aid groups, got involved in volunteering schemes. So lots of really good positive feedback about that. We ran a COVID Heroes campaign about 4 weeks into lockdown, and that resulted in 2 people coming out as people who received the highest number of nominations, one pharmacist and one sort of fitness instructor, who obviously were just doing completely different things, but who had made the experience of people in their communities significantly better. Next slide, please. In terms of concerns, I think something that will come out a lot in the conversation today is about the experience of decline in people's mental well-being, be that people with pre-existing mental health conditions or people who are experiencing difficulties with their mental health now during this time. As I mentioned on the previous slide, actually, miscommunication has been at the root of a lot of the negative feedback that we've heard. So examples of people not being told that medication is ready, or that it isn't ready and that they need to go somewhere else for it. People not being kept up to date around loved ones' well-being, that type of thing. We've heard some concerns about using NHS and social care, and as Rachel mentioned, the campaign I think has been really, really helpful, but we're still getting people saying they don't want to be a burden to the NHS at this time, or that they're worried that they'll contract COVID-19. one of the things that we've heard that we feel is quite concerning is a couple of quite detailed stories from people who have had critical health problems missed due to suspected COVID-19. So a person who had a stroke, a person who had heart failure, where the families have certainly felt that the care was influenced by the presence of COVID-19. I'm sure it'll surprise nobody on this call to know that we've been receiving feedback about dentistry. So lots of feedback from people who have struggled to access the urgent care that's been available, and delays in terms of getting urgent dental care centres up and running in Kirklees by comparison to different areas of the country. We're hearing more feedback now about a kind of change in the attitude of the community around COVID-19. So sort of people being less understanding, particularly around things like invisible disability. So people being turned away at supermarkets because their disability isn't visible to the people who are making those decisions. And there's been some concerning press coverage about transfers between hospitals and care homes, which has prompted some people to contact us with their concerns about that. The feedback changes literally every single week at the moment. So this is something that I wrote at the back end of last week. There's different things I would include today, particularly around shielding, and some feedback we're getting about mixed messages around shielding. So we're trying to make sure that our feedback is as live as possible. But that's all.
Thank you very much, Helen. So Phil, is this back to Rachel?
Yes, over to me now, Councillor Kendrick. Thank you. So just very briefly from the council's kind of corporate centre perspective, staff wellbeing and capacity in terms of how we manage that service delivery has been at the heart of our response. Real challenges to get us digitally enabled to work from home and ensure that we've got those safe working environments for those staff that needed to work from an office location or other locations. But certainly, I think from my perspective, the efforts of our IT services to get things up and running has been incredible. Staff have been fabulous, hugely resourceful, and we were able to understand skills that we didn't know people had, which helps us with future workforce planning. I think that whole kind of how we ensure people's experiences and anxieties are reflected in creating more flexible working environments and times, particularly with managing childcare or other commitments. Managing virtual meetings such as this one, and obviously trying to be clear on getting the democratic accountability there has been really interesting and challenging, and it will help us, I think, in the long term, make decisions in a new way. Next slide, please. Just in terms of finance, and again, these are sort of headline figures. It's still early days in terms of what the financial impact is, but it could be anywhere between 34 million and 65 million. Obviously, there's a level of income loss, as you would expect, in terms of fees and charges and business rates, etc. We've had funding to date in terms of relieving some of those cost pressures which we're using. But I think actually the real point for me is how we look at this in the longer term and understanding the impact both on an organisation, but obviously at a societal level as well, and how we work with governments both regionally and nationally to ensure that we end up with less impact. Next slide, please. I'm going to pass over to Emily, who's going to talk a little bit more about what the public health team has been doing during this. Emily?
Thank you. Just a couple of slides from me, one more broadly around public health, and then one that very quickly talk about the efforts that are being made around the shielding population. A lot of what I'm going to say chimes very closely with what Helen was saying from healthwatch, but the four main things: rapid improvement in relationships with partners. They were already good, but they're better now, but specifically with reference to improved data flow, and when we're thinking about the things that we want to protect that have been benefits seen through COVID, we really need to protect those data flows and make really rapid progress on the population health management work that we'd started. Really good, positive learning around the use of technology to support remote consultation for our most vulnerable populations. We need to think very carefully about digital exclusion and making sure that that doesn't go anywhere to increase health inequalities, but the feedback that we are getting is that where it is used, it's being used to good effect. Massively valuable opportunity for the public health staff to be involved in frontline service delivery. We've had a lot of public health staff out in the food banks and mobilising that initial community response, and that's going to stay with us and inform our thinking as we move forward of this. And then I think the most important thing for me is the really rapid acceptance of the role that inequalities are playing in the impact and experience that people are having of COVID. It was already very, very important to us. It was already front and centre in things like the health and wellbeing plan, but absolutely clarified in the data that we're seeing come out around COVID. Next slide, please. I'm just very quickly going to talk a little bit about the shielding population. So this is a specific cohort of the population who've been identified as being at more significant risk of COVID. It's a list of specific clinical conditions from things like solid organ transplant, certain types of chemotherapy, severe and uncontrolled asthma. That list covers about 18,000 people in Kirklees, and those people are being asked to stay at home and were initially being asked to stay at home and not leave their homes at all. They've now been advised that they can meet with one person from outside of their household outside, but observing social distancing and hand washing. We've needed to mobilise very, very quickly support packages for those people in order to be able to shield. That's included access to medical care, medicines, food and social contact. We've achieved that by putting a local infrastructure in place, aligned very closely to the community response hubs, and really, really importantly, hyper-local knowledge and information from our VCS and anchor organisations, and been a real cross-council and cross-CCG effort as well. Actually, we've had really good involvement across both the council and the CCG. That's all from me.
Thank you very much. I think, according to my list, it's Richard Parry.
Thank you, Chair. So I wanted to just reflect on where we're at so far with adult social care. Just as we really started to move into the lockdown period, there was legislation passed that allowed us to move away from some of the obligations on the council under the Care Act, this notion of Care Act easements. There's a process to go through if a local authority decided as it got to the point where it needed to enact those easements. We've not needed to do that. We've been able to stay within our normal operating models, with the exception of some changed work around hospital discharge processes, where we've worked with neighbouring councils as well as our two acute providers and Locala to ensure we've got more rapid discharge processes for individuals. Critically, I think the things that we saw as a priority for our local social care system and the values that we had in, say, February have remained unchanged. That focus on working with individuals, putting them at the centre of everything that we do, looking to maintain and maximise people's independence and to draw on all the things that support people have guided our work in this time. But what we have done is scale up the amount of work that we've been doing as a directorate with people outside of the formal social care system, and that touches on some of the more formal groups of people that Emily's already talked about in terms of those people who are shielded, but other people who have been concerned about how they were going to manage risk in the intervening period. And that's used particularly our Community Plus service that we already had in place, but also other services like our library service has stepped in and offered quite significant levels of support. In terms of some of the current challenges, PPE dominated the headlines nationally in the early weeks. We're at a position where it's not dominating the headlines, but that doesn't mean to say that it is entirely resolved. There's slightly more confidence in supply, but given that, particularly if you're working, say, in a care home environment, the demand in terms of PPE has not changed and will not change for a number of months. It remains an area of concern in terms of just continue to have continued confidence that we've got the right access to PPE and that staff are confident in its use. We've seen in recent weeks a significant step up of the support to care homes, a multi-agency approach. So both infection prevention control colleagues within the council, but colleagues from CCGs and Locala in particular, supporting all of our care homes around infection prevention control and the use of PPE. We've upped, as I say, our kind of support program to external care providers. I think, though, that there remain some challenges and perhaps a tension between the local priorities and the national priorities, for instance, for access to testing, where the national priority has been about larger scale care homes, and particularly care homes for older people, whereas locally we would recognise that particularly residential services support people with a learning disability are supporting some particularly vulnerable individuals. We know that nationally and even outside of COVID-19, health outcomes for people with a learning disability are markedly poorer than they are for the general population. And so that remains a local priority, but that jars to an extent with some of the national prioritisation. And whilst we are seeing some easing nationally of the lockdown position, and we're now in a position where if we choose to, we can go and queue for a burger, actually a number of our services, the world has not changed. If anything, the level of pressure is increasing. So if you're working in our Community Plus and providing that informal support to individuals working alongside volunteers, that's an area where we're not going to be easing out of lockdown and pressures anytime soon. We know there's a very significant level of pressure on informal carers, and again, I think if you're in that position, and I know that healthwatch colleagues and indeed the integrated care system, the health partnership program, informal carers continue to flag that as an area where there's significant pressure, and again, that's going to continue for some time to come. But we have learned a lot. Remote working and using digital technology has generally been successful. I think it's challenged some people's notion of how you can use technology and how it works effectively for people. I connected with our learning disability team the other week, and they were talking about how mental health review tribunals, this is for individuals who've been detained in hospital under the Mental Health Act, are now taking place virtually, and actually that for many people, individuals who've been subject to that detention hospital, actually that virtual meeting is much easier to manage than walking into a physical room where you've got a number of clinicians and legal professionals. But we do know it doesn't work for everybody. There are some tasks that you cannot do digitally, you cannot do remotely. And we also know that for some colleagues who are working in particularly challenging situations, dealing with some particularly distressing circumstances, doing all of that working from home and not having that immediate support of your colleagues is difficult. And we know there's a really careful balance to be struck between welcoming and working alongside all the community capacity that's come to the fore in recent weeks, but making sure that we support that, but we don't get in the way. We, as kind of large-scale organisations, need to be respectful of that. But I think it's really positive in terms of the opportunities as we go forward in terms of developing our approach to primary care networks in particular, and seeing those as kind of part of the bedrock of future community support. Now, at this point, I need to offer an apology. It's really important in any health and social care system that the Director of Adult Services and the Director of Children's Services work very closely together. And so the next slide is actually one of Mel's slides, because I saw some material that she had produced and worked off that. So this is, I've added this one in error. You'll see it duplicates one of Mel's slides.
Can I just say, Richard, that Mel's had to leave the meeting because of an urgent issue. So I didn't know if you were in a position to talk through some first
I can
slides.
happily talk through her slides, yes. So Olivia, I wonder if we could just move on to slides. I had slide 16. So again, the national priorities for children's services remained unchanged. I think Mel would say that actually working with partners has become even more important in this time, and as with adult social care, hearing the voice of individuals and what's important to them has been critical. that's, I think, been some of what colleagues have been exploring in terms of Olivia, could we just go back up one slide? Some of the work around increasing access to schools has very much been about hearing the voice of the child in that and what's important to children. So, Chair, if you could just pause a minute, I've lost sight of the slides. Could we just go off one slide? There we go. Thank you. And you know, there's this first point in terms of balancing the national and the kind of local needs. I was probably familiar to a number of colleagues in different organisations where it's been really important to understand the national drivers, the national priorities and context, but also actually our local position and what will work well for us and get the right balance between the two. Coming down a bit, I think one of the very early doors, one of the conversations that the council had with our colleagues in CAL, Kirklees Active Leisure, was their ability as leisure centres closed to be able to support social care more generally at a point at which we didn't know what the pressures were going to look like. And there's a really good piece of work undertaken which upskilled a number of colleagues from CAL to be able to support the social care sector, both within the council, but also to be able to support our independent sector providers. And that's worked particularly well in terms of supporting some of our children's social care establishments where we have a number of CAL staff deployed, providing support into those services where there's additional pressure. And then just kind of finally, I wanted to pick up this very bottom bullet point, which is, I think, one of the things that this has brought to the fore across the whole system, and but particularly within children's services, is brought together a number of the networks that perhaps existed but have been strengthened through this process. So working particularly with partners, the support from corporate colleagues, particularly around things like IT support, enabling us to move on to a much more digital way of working, but critically also getting data to understand the situation that we're in, and as that has rapidly changed, to enable really good quality decision making. And so if we could now move down one slide. I think, you know, this slide is a slide that could apply to many organisations about the way staff have responded, the way in which there has been innovation. We've tested out things within children's services, as indeed across all organisations, that we've talked about for a while, but didn't necessarily have the confidence. We've been forced to leap into those. We need to now learn the lessons and build on what's worked well and retain that. Where there are some things that we, with the luxury of time now, can improve on, we should be doing all of that. And it's interesting, just this very last point about, I think we've all suddenly had to get to grips with something around social media and how we use different platforms. For some of us, it's felt a more painful process, but actually I think it'll be really interesting to see how we use that to engage with young people, but actually to engage across the generations. We've talked about kind of intergenerational working to do all of that. Thank you, Chair.
Thank you very much, Richard, and thank you for stepping in at such very, very short notice. So, I understand the next speaker is Ian Currell of Greater Huddersfield North Kirklees CCGs. Welcome, Ian.
Yeah, thank you, Chair. And yeah, just a couple of slides. Give an update on behalf of both CCGs, and apologies that Carol McKenna couldn't be here today. So the CCG has a particular role around system oversight and coordination. So looking at the presentation slide, looking at the command and control structures. First of all, we all know Kirklees is a fantastic place. Also, it is quite a complicated place. So we have two acute trusts, 2 CCGs. So what that means in the sort of command structures in response to COVID is that on the one hand, we're the health rep on the Kirklees Gold that's chaired by the council, but then equally we also play into the on the Mid Yorkshire footprint around their command structures, and then also on the CHFT footprint as well, and try and sort of bring that back and make sense for Kirklees. Commissioning at pace. I think some people would say that CCGs aren't particularly well known for commissioning at pace, but that is what was needed at the start of the response. So we changed our governance structures to enable us to respond more quickly. I think in 2 months of COVID, we've probably done 12 months worth of decisions that we normally make. So certainly we've been far more rapid in making our funding decisions, changing the services that we deliver, the quality impact assessments that we do, the sorts of things that would take a lot of months to do, we've been doing in sort of in weeks or in days. So that's certainly a bit of learning for us. Communication and liaison. I think after any sort of major emergency, one of the learning points, isn't it, is always around we could have communicated better. So I think we've made a real effort as a CCG to try and put effort into how we communicate. On the one hand, that's from a sort of up the chain to NHS England and sort of feeding the national beast around communications there. But probably more importantly is at a local level with our partners. And then particularly with primary care, we put an awful lot of effort into making sure, all of our 60 odd practices across Kirklees don't feel like they're operating in isolation, and that we get that communication right. Partnership support and leadership. We're not a direct care provider, so nearly everything that we do by working in partnership. So I think the support to care homes is probably quite a good example of that. It's work with the council, it's work with Locala, it's work with primary care, and us all bringing all that together to try and get that support into care homes. So partnership working has been really, really important. And then membership practice support. So we're a membership organisation, and although we play into lots of other things, we feel that we've got a particular role around primary care and support to our GP practices. So as already mentioned, part of that support is getting the communication right. So there's been daily bulletins out to primary care, phone calls with each practice twice a week. There's been short-term financial support that's gone out to practices to enable them to better respond in the right way, and support around the change to the care models and the way services are delivered in primary care. Next slide, please. And then just a little bit more about how primary care has changed and how it'll feel for our population. We've been, I don't know if it's years, we've certainly been trying for a long time to move to more non-face-to-face models of delivery, and what was taking years or months suddenly felt like it happened overnight, and part of that was getting the IT right. I think all practices across Kirklees now are doing the majority of their consultations by non-face-to-face, and that's a huge change from before COVID, and that happened really, really quickly. Having said that, there's still a significant number of consultations that need to happen face-to-face, and will always need to happen face-to-face, and rightly so. What's been important during the COVID response is that those face-to-face consultations, we split COVID patients and non-COVID patients and make sure that they don't mix. So for their face-to-face assessments for COVID patients, we set up 2 sort of hot sites, as we've called them, so one in Dewsbury and one in Huddersfield. So if you're a patient and you need a face-to-face primary care appointment, you go to one of those 2 hot sites. We've also set up a home visiting service for COVID positive patients and people shielding at home. If you're a non-COVID positive patient and you need a face-to-face, then you will go to your normal GP practice and be seen there. And then also there's the support to care homes, which particularly feels like it's ramped up over recent weeks. And, you know, primary care always supported care homes, but that's been increased. There's now, you know, if it wasn't happening already, there's now a weekly, from the 1st of June, there's now a weekly sort of virtual ward round at each care home by a multidisciplinary team and including the GP, and every care home, as well as the named GPs for each of their patients, they have an overall named clinician as well that the care home can make contact with. So a lot's changed in primary care. And then just finally, quickly, learning. What's our learning and what's the future? I think, like other people have said, the strength of partnerships have been really important. If we deliver something, but just because we've got a contract with somebody, then we're on a bit shaky ground anyway, aren't we? So we deliver something because people want to deliver it because we're in a really good partnership with us. So I think that's been shown to be really, really important. I talked about the decision making. So lots of things have changed, and part of this is going to be holding on to what's good and making sure we take about how the NHS is going to be in the future. And then just very finally, engagement with our residents. I think, I don't know if whether it's one of the negative, but I think because we've responded so quickly and made fast decisions, it's not been possible to engage with our residents during that period in the way we would normally do with service change. So certainly if things get embedded and we move forward, we need to make sure that we are engaging with our residents to help inform how, you know, what we keep that's good and what we ditch and how we change our services in the future. And that was the end of the slides. Thank you.
Thank you very much, Ian. Phil, I think you're going to do the next slot for us on NHS England.
Yeah, I'm not going to attempt to cover in depth what Catherine would have done. One of the reasons why there's probably a bit more detail on these slides is that we thought that slides hopefully could speak for themselves, and Neil's on the call. So if there are any questions, if people could type them in the chat and then we can address them at the end. So next slide, please. So I'm sure most of the people at the meeting will know that NHS England have got a critical role in terms of coordinating things on a sort of more strategic level, as Ian has just referred to. And there's been a huge amount of work. The particular focus in terms of commissioning that's probably relevant here is around dentists, opticians and pharmacists. So that's what's covered on the next few slides. Next slide, please. Helen's already mentioned issues around dental. I won't go through the detail, but dental practices have remained open for telephone access, and we've had 5 urgent dental treatment centres open in Kirklees, and we've also been involved in making sure they've got access to the PPE that they need, and there is actually another delivery going out to them tomorrow or Monday to make sure that they can operate safely and make sure everybody who's got an urgent dental need can get treated. Next, please. Again, optometry remained open, but in a different way. I'm not going to attempt to read all the detail on it, but hopefully people can. Next slide, please. Again, a lot of work with community pharmacy to make sure that people are getting access to the drugs that they need, and that's been a focus of a huge amount of activity with Community Pharmacy West Yorkshire, working very closely with a range of local services to make sure people can access the drugs that they need. Next, please. I think Ian's already mentioned some of the issues around general practice. Perhaps the one to pick up off there is around screening and immunisations, because I know there's significant concern about the drop-off in rates because of people's anxieties about attending general practice, but sort of routine screening and immunisation. Just picking up on dental, again, people have probably seen from the national announcements, dentists are able to open again from next Monday. And there's a lot of work going on to make sure that as many of those practices who feel able are able to open. Next slide, please. Again, quite a lot of similar issues to previously on here. I think one of the issues I'll just pick up out of that is about winter preparation, because it hasn't been mentioned this far, but I know quite a lot of people are already starting to think about, bearing in mind the way in which services have changed. That's going to mean that we'll need a significant amount of thinking about how to make sure that we're ready to respond to the potential increase in demand for services across winter. Okay, next slide, please.
I think we're then back to healthwatch, aren't we? Thank you. So Helen Hunter again, please.
Yep. So obviously we are a significantly smaller organisation than those that have kind of presented so far. So it's a little bit different in terms of the flavour of how things have changed for us. At healthwatch Kirklees, we've had to completely redesign our full programme of work for the year because we are unable to do what we were intending to do when we set our strategic plan at the very start of the year. And we've focused our plans going forward around 4 key areas, and the areas I'm going to go through them in the order almost in which they started. So when lockdown first began, we realised that our role was very much about clearly communicating with the public, using our mechanisms around public health messages, and particularly about the availability of services. We have a frequently asked questions sheet on our website, which we update with national guidance, and we update with local information as well. We just wanted to make sure that there was that clear information out there. We've done some work supporting the community response. So a lot of our staff have signed up as either NHS volunteers or signed up with local volunteering schemes, as have volunteers of healthwatch. And we've been delivering a sort of in-house befriending scheme. So we have a number of staff who have been contacting people with whom we already had a connection, either after having visited a community group or something like that. And we've been offering one sort of a telephone call each week. We've moved into gathering the public's views and experiences at this time. So we launched a survey last week to ask people about their experience of accessing health and care, and we've had 182 responses for Kirklees so far. We have an information signposting service that has continued, and people are contacting us and asking lots of questions about how they access services, what they are and aren't entitled to, that type of thing. And we've got a larger project plan that will cover some story gathering, so we're hoping to get people to tell us their story in different and creative ways about their experience of accessing health and care across this time. And the last part, the part that falls with me, is about influencing health and care delivery. I've been on an awful lot of calls over the last few weeks trying to make sure that any of the feedback that we are pulling together, which so far has been summarised in a number of feedback summary reports, is landing in the right pathways, in the right work streams, so that it can have a real influence over how we sort of reset and redesign as we go forward. So that's still something that we're giving real development time to. And we've had a big focus on staff and volunteer wellbeing. We've had to offer flexibility around working hours because of childcare. And we've done a lot to encourage peer support. Actually, the team have been fantastic. In terms of challenges that we're facing as an organisation, we have always been an agency that has gone out to people where they are and gathered their feedback whilst they're accessing services or accessing sort of a community group support. We cannot do any of that at the moment, and that significantly impacts the way in which we would normally deliver things, how we're doing it now. So we're having to be an awful lot more creative, and I've got some fantastic colleagues who are really innovative, and we're looking at doing things in lots of different ways. It's really difficult to gather the voice of people who are not digitally enabled in particular. So of course we can share our survey on social media, we send emails out to people. It's much more difficult at the moment to actually have that contact with somebody who doesn't have that sort of access. We're particularly concerned about the voicelessness of care home residents who we would normally be able to visit a premises and go and speak to people, and family members would normally be able to go in and give us more feedback. We don't have any of that at the moment, and we're experiencing some additional barriers around gathering the voice of BAME communities who have obviously been disproportionately impacted by COVID-19. So we're working on those two work streams. I'm not sure that's my slide.
Is that the end of?
Just go forward one. I've got one more slide. There we go.
Yeah.
So in terms of our learning, we're learning that some of our communities are very willing and able to be engaged through digital means. So we've been running some focus groups using Zoom. We've been using our social media in sort of ways of gathering polls, that type of thing. So we've been using things in a variety of different ways. We were really quickly able to set up working from home because everybody already had that capability. So we literally were able to basically lift everything out of the office and go and work from home straight away, and that's really helped. Something that I feel is really important learning is that we are speaking with a number of people at the moment for whom our community response to COVID has actually improved their quality of life. People who were incredibly isolated, who never had anything like a befriending call every week previously, never had food parcel deliveries, but were still struggling, who actually almost feel like, although this has been a very challenging time, that their experience has improved. And I think it's really important that we don't lose some of that stuff. And I think it's really important to reflect that actions speak louder than words at the moment. As we rebuild, any comms, we can put lots and lots of comms messages out, but what we choose to do and the order we choose to do it in tells the public what is most important to us. So we need to be really responsive to that and make sure that our actions match up with the communications messages that we're putting out there. In terms of plans for Healthwatch, we're going to continue with our COVID engagement over the summer, and that will include some specific work engaging with care home residents and some specific work engaging with BAME communities. I'm trying to develop and reinforce pathways for sharing our learning from our reports. And we're doing a clear examination of our working practices and looking at what Healthwatch will look like in the future, because our office in Kirklees is not fit for purpose, and we need to make sure that staff are safe if we're going to be asking them to go back out into communities again. Thank you.
Thank you very much, Helen. Thank you. So, Karen Jackson from Locala.
Hiya, thank you.
Hello.
Hiya. So we've put two slides together covering service priorities and then some of our cores. I'm just going to start off by a bit of an introduction. I'll hand to Jane, who will take us through the slides. I just want to say what has been absolutely inspirational for us is the flexibility of our colleagues and the way that we've worked in partnership, which has moved on significantly right across the patch. So that's all of us as a system working in partnership together to address these issues. We are working really closely with Healthwatch now to engage with the people we look after to make sure that whatever we do turn on or off as a result of the next steps in this actually reflects their experience of what services we're providing and how we're providing them. So it's been, in some respects, it's been a really positive experience. So I'll hand to Jane and she'll just take you through the two slides. Jane, please.
Thank you. Okay, so in terms of, like many others have just mentioned, we did a piece of work initially in line with the national guidance to look at what services we either reduced or turned off. In actual fact, we didn't turn any services off. We turned a lot of our services to virtual consultations. And the important thing probably to stress is our predominant district nursing services, intermediate care services have actually maintained, or indeed in some instances increased the levels of activity in response to COVID. System-wise, we have had a big part to play both in colleague testing. So we run the testing site in Kirklees, and that's open for any staff member of ourselves, of the acute trusts, of primary care and of the local authority and hospices. We've done a big piece of work to support discharge management alongside the council and the acute trusts. We are part of the hot sites that Ian alluded to, as well as the care home support and the vulnerable patient home visiting service. The focus that we've got now is to look at our service priorities as we start to reset, recover the new normal, whatever the latest terminology is. And we are working through a number of task and finish groups that are internal to Lacala and then go out into the wider system across Kirklees, but also working very closely into Wakefield as part of the Mid Yorkshire's acute footprint. The same is starting in CHFT as well, so that we're really keen to make sure that where possible, as we turn the community service provision back on across the CKW footprint, it's done with some semblance of order and actually that we're all doing largely the same thing where we need to. So we've looked at our risk factors around our vulnerable patients, utilising population health management. We're doing a big piece of work to understand our demand drivers in community services that will give us the ability to then look at which of the service areas we start to recover first. Understanding our clinic activity, and by that I mean the work that we need to do around social distancing, so we won't be able to see the same levels of activity in clinic environments that we would have pre-COVID. So looking therefore, how many more clinics do we need to meet the demand, what does that do to the waiting lists, etc. Looking at the colleagues in our services that we reduced, we actually redeployed them into predominantly into our community nursing services and our intermediate care services, and then looking at what that does longer term. If we remove those redeployed colleagues out of those services, can we still cope with the increased demand that we've got? Looking at our high risk patient groups, and then continuing to provide our critical and urgent care for COVID-19 patients that require recovery and rehabilitation. So from our point of view, we didn't see the predicted increase in discharges from the acute trusts post-COVID. What we found is we've seen a significant increase in our activity of patients that require a note to our response. So the as I call it, the rapid response, and a large proportion of those patients are COVID symptomatic or COVID positive patients. And then again, supporting the effective, safe discharge from communities and making sure in all of this as we start the reset work that we keep, as everybody else has alluded to, the really good things that we've done. Next slide, please. So in part of this planning, we've started to look at what our risks are in the immediate and short term. And I think the important thing to say is short term and medium term and longer term in COVID aren't the normal short, medium, longer term. So actually looking at what capacity issues might arise with our new guidance of isolation of asymptomatic positive staff, looking at our capacity to deliver all of the requests to support on an ongoing basis. And then in terms of opportunities, virtual consultations, doing a big piece of work with our colleagues at the moment about what's worked really well. And again, the move to virtual consultations is something we've been struggling with for quite a while. This has given us the permission almost to actually make it happen really quickly. And colleagues have really responded to that as well. Our risks around our medium and longer term around our acute elective activity, to make sure that we can respond to support the acute demands whilst carrying out our refreshed community service delivery. We are planning around probably in terms of winter, but also whether or not we plan as well at the same time for the second peak that is talked about and probably anticipated. All of our service turn on, service reset is dependent on our ability to secure PPE, and we have got a big focus on training and flow of our new recruits, because there will be our future without a doubt. In terms of success, again, alluded to through the presentation in terms of joint working, and recognised, Lacala recognised for that joint working. The testing sites that we've given support to across CKW, and what we've done to support the CKW footprint around all of the testing sites is that actually our single point of contact have actually taken all of the referrals for the CKW footprint. And again, as I mentioned at the start, the input into the home visiting service. Thank you.
Thank you very much. That's really helpful. So we now have from Mid Yorkshire Trust, Matt England. Can I just mention, Matt, we had that initial question from Councillor Zaman, which hopefully you're going to be covering in this presentation from your trust.
Yeah, will do.
Thank you.
Okay, thanks. Good afternoon, everybody. Can I have the next slide, please, Phil? So in terms of what we've done at Mid Yorkshire, established a robust command and control structure within the trust, and then obviously in kind of early days of the COVID pandemic, we undertook the rapid reconfiguration of services, establishing Pinderfields as the red site or the hot site, and also increased our critical care capacity, and with scope for further increase should that be required. We've then obviously been cohorting patients in terms of non-COVID and suspected and confirmed COVID throughout the hospital pathways. We've also, in recent weeks, undertaken work to establish Pontefract Hospital as a green site and to operate it as a cancer centre to support continuation of some of the cancer services and some of the surgery that needs to take place. We've had quite good discussions with our PCNs, both in North Kirklees and Wakefield, around the plans that we've got for restarting planned care. And I think, as been mentioned by a lot of people in their presentations, we've seen a big shift to virtual appointments and non-face-to-face, and also implemented rapid discharge pathways with partners. In terms of the staff health and wellbeing, we've done a lot to try and secure the right levels and right type of PPE, and there's been quite a significant work stream on that in recent weeks. It continues to present some challenges in terms of particular products. A lot around staff testing and providing wobble rooms and psychological support. And we've been able to enable home working for a lot of staff where appropriate, and being able to kind of distribute IT kit quite quickly to allow that to happen. We've also, I'm sure as many organisations have had, fantastic support from local businesses and members of the public and the community, making donations of food and drinks and other items, and we've been able to distribute those out on an equitable basis to our frontline staff. Some of the current challenges, we're working to plan to recommence our elective and planned care. Obviously there's a backlog of patients who were waiting for procedures prior to the kind of suspension of services, so we need to plan on how to kind of bring those services back online, and then also to reopen to referrals as well into our services. We're working to rapidly develop new planned care pathways, using clinical triage of all referrals, and where possible offering virtual appointments, and only aiming to bring people back onto hospital sites for a face-to-face appointment where it's absolutely necessary. Staff and patient testing continues to be a kind of priority, and we've established the antibody testing, commenced in the trust on Friday. We've got a significant proportion of staff have taken up that offer, and we're now turning around those samples to give people results. As I mentioned, PPE, it continues to be a significant rate limiting factor around restarting some of the services, particularly on specific products, and that ebbs and flows as products become scarce in supply, and then supply starts to recommence. So we're working with that on a daily basis to identify what PPE we've got, what PPE we need, and how we can turn services back on. And I think was mentioned in the locale presentation, the capacity that we will be able to provide is significantly impacted by implementing social distancing. And again, kind of the plans are being worked at the moment to just kind of understand exactly what that means in terms of capacities of numbers of patients per clinic, number of patients per theatre lists, and that will, ensuring that people are safe and adhering to those social distancing principles will have a significant impact on our capacity. In terms of the question that was asked in relation to discharges, so I've got a response from our incident commander. So all of our non-elective admissions are tested for COVID. If the test comes back positive, then they're obviously treated as a COVID patient within a red area of the trust. If the first test is negative but they remain clinically or radiologically positive, then they're retested and treated as if they are COVID positive. In terms of discharges, all patients are tested before discharge. A positive test doesn't necessarily prevent the discharge, but we work with the care facilities, social care and residential care in terms of informing them of that positive test. If they're unable to take the patient back because of that positive test, then we work with colleagues across the system to find an alternative. In terms of our planned pathways that are restarting, we're implementing testing before patients come in and also asking around self-isolation for a period of time. And so we're implementing one test, I think it's 72 hours before the patient's due to come in.
Thank you very much. Thank you. And then we have Anna Basford from Calderdale and Huddersfield Foundation Trust.
Okay, thank you very much.
Sure.
I think what I'm going to say will very much resonate with what Matt's just said. The pitch is very similar within CHFT and the actions we've taken and some of the challenges we now face. So just in terms of the service changes, we've had to implement testing of all patients, non-elective patients admitted to hospital, coming into hospital, and then ensure that we can provide isolation or cohorting of those patients into segregated areas, dependent upon whether they are COVID positive or negative. We've needed to stop all non-urgent and non-emergency work around outpatients and diagnostics and elective operations. We have provided digital options to access virtual consultations and also for patient visiting, so family members can undertake visiting via digital options. There's been significant redeployment of staff within the organisation, people moving away from areas they normally work, being trained and supported to work in new areas to create additional capacity in our preparation for a surge around the pandemic, and significantly around the focus of that being to increase our critical care capacity. We developed plans with sufficient equipment and staffing to move our critical care capacity from 13 beds up to 48, almost a fourfold increase in capacity, reliant upon significant work around sourcing appropriate both skilled staff and the equipment and the segregated areas to do that in. And also some of the hospital infrastructure issues around oxygen supply and flow in our two sites that has necessitated for us at CHFT that we have used both sites to receive COVID patients, both in Huddersfield and in Halifax, whereas I know by contrast Mid Yorks has been able to do that on a single site at Pinderfields. In terms of some of the new ways of working that have come about alongside these service changes, there's been some really incredible partnership working and the support that with partners and collaboration. So particularly with social care around discharge pathways, which have been referred to quite significantly today, around working for us with both hospices, particularly around end-of-life care, around the provision of specialist in-reach into the hospital from the hospices for end-of-life care, and agreeing pathways for those, and also working very closely with Ocala and general practice. We've also worked significantly with independent sector hospitals to try to protect cancer surgery on sites outside the hospital, where our surgeons are providing the actual surgery have been, but there have been independent sector staff have been able to support that with the facilities and staffing. In terms of colleague wellbeing, again, a very similar picture. Very detailed work undertaken around the provision of PPE equipment and about the training of staff about how to use that safely, about training them to work in new and different areas, and alongside that significantly around the support we provide to them in terms of counselling, psychological support, wellbeing support, the ability to work at home. Excuse me. We have ongoing challenges, as Matt has referred to, and I think it's common across most hospital settings around, and most settings, is around the PPE supply. We don't have a problem with it, but we recognise, planning for the future about certainty of supply around particular products, particularly in planning to increase the volume of work that we do, is challenging. Similarly, with testing, being able to have sufficient reagent for testing of staff and patients. Also around our estate, the fact that we now have to ensure absolutely the segregation of positive COVID patients, and for those for whom we're awaiting test results or are negative, means that we have to use our estate in new ways, which limits our capacity. If we go to the next slide, please. What we have learned during this period of time is that by working together across the system and with partners, we can work incredibly quickly and at pace to make significant changes. And there's been a real sense of working together to do the right thing, to make services as safe as possible for members of the public and for colleagues working, delivering care both in and out of hospital. And we've also learned that some of the changes that we've made have been really positive, and that's been referred to consistently around the use of technology, about working from home for colleagues, around enabling specialist review through the use of digital technology, and in reach into a number of different care settings. Our plans for the future, I think we would describe them as being cautious about how do we restart services in a way that we can make sure that we sustain that safe environment of care, and that we're able to do that and also protect colleagues. We're currently modelling what our demand and capacity we will be able to offer going forward, given some of the constraints we have around PPE equipment, the estate and staffing. We're also very mindful that we are in these months looking ahead in a context where we are preparing for winter, where we would normally see increased numbers of people coming into hospital, and also the potential for a further rise in the number of COVID patients. So one of the key pieces of work that we've commenced is something that we're called about being better than usual, which is really that we want to take forward all the positive change that's been implemented and make sure we carry that forward into the future, and to learn from colleagues who've been delivering services. So as part of that, during May, we've been undertaking structured learning internal to CHFT, but also with partners, and collating that to draw out key themes about how we move forward over the coming months together and with partners in our systems. And I think really important to that is absolutely recognising however we plan to recommence services in the hospital needs to be absolutely as part of an overall system response, because every part of the system needs to be working together, understanding the impact. So those are my 2 slides. Thank you.
Thank you very much. Thank you. So next speaker is Tim Breeden from South West Yorkshire Foundation Trust.
Thank you.
Thank you.
Some of the things that inevitably, I guess, will be similar to the points that Matt and Dan have made, so I won't rehearse those. Some of those are in the slide. Clearly, same as others, we've established a normal command structures within the organisation to deal with the pandemic, but importantly, we've been making sure that we've linked across all other command structures within the system to make sure that we contribute, because we felt it's important to ensure that the issues that I think recognised earlier on around the mental health concerns that people may have during this time are acknowledged and supported throughout the system. In terms of managing our own services, we ensure that we've just kept things going primarily through digital office, making sure that we're available to get services continuing through sort of virtual response using telephone, face-to-face calls, but also going out and visiting people using the necessary PPE wherever that is necessary and possible. We've been ensuring that we maintain the flow through our systems. I've lost the slides there, sorry. I do know most of them, but what I can say while they're coming through is that we've been maintaining the flow through the system from our services because of the importance of the impact of understanding how that affects others. And I think it's been important also from our perspective to ensure, thank you, to ensure that we support timely discharge. And that has been one of our key areas of interest during the last few weeks. I think to make some of the things happen that we just talked about before in terms of the virtual response has really meant that we've had to respond very quickly in terms of supplying a number of people with the IT kit to either work, as I think has been mentioned before, I think mentioned from the Locala perspective, making sure that people can work at home wherever this is possible. And that's been a massive speedy deployment from our IT team to allow people to work in the way that I've just described and use some of the technology that is out there that people actually have appreciated. And we have had some positive responses from people about the way we have maintained contact. In terms of our key concerns at the moment, the big challenges we have are and the things that we anticipated early were people who have a long-term psychosis have found this pandemic particularly concerning, and we know that we've had to provide additional support, and we're already seeing some of the impact there upon their condition coming through into services in terms of increased demand. We also know that there's going to be a long-term increase in demand across mental health services, and planning for that increase is clearly important. But the key challenge for us there is not so much the fact that we know about that the demand is occurring, it's when it's going to happen. We don't really have anything that can inform us particularly clearly on that, so we need to work hard on understanding that in the next phase. Can we just move on to the next slide, please? In terms of the learning, I think as I said before, I think the people have seen benefits from the face-to-face contact. Using the technology rather than the face-to-face contact in some instances, and we need to understand why that has been beneficial. There's something probably in the initial view is probably more about frequency than anything else. There's definitely been some learning on the benefits about the use of Microsoft Teams as we're using today for making sure that we keep people together around meetings and training, supervision, etc. And that has actually improved the offer there for colleagues in terms of keeping them alert and organised, I think. And that's people have certainly felt the benefits there, as I say. We've put a number of things that we would have normally done in classroom style approaches in terms of learning online, and again people have appreciated that, and again I think has probably been a little bit more efficient. The other things I draw attention to I think has been on and off through the presentation this afternoon, the learning from our ability to use our command structures appropriately has definitely improved the speed of decision making and our responsiveness, and we need to learn from that for next phase. Many people have mentioned about staff support and peer support. I don't think I'll go through that again. The big thing for us now is I think Anna's just talked about this as well, just making sure that we understand what it is that we want to keep, that we've changed, and what it is that we need to stop doing that we've only done in exceptional circumstances and have been of no benefit. We need to do a lot of work on that, and specifically we need to look at, as I've mentioned throughout here, that we understand the effectiveness of all these virtual interventions, because there has been significant benefits for some people, as we can see, but I'm sure there's other things that we need to understand. And the big bit from the States obviously is going to be making sure we've got the right sort of work environment for people when they do return. So I think I'll leave it there. Thank you.
Thank you very much, Tim. That's really interesting. So we have now from third sector leaders, Val Johnson. I hope.
Sorry, I'm just unmuting. So I'm just going to take you very quickly through the development of community anchors in Kirklees and how they responded and worked with all the thousands of volunteers that came forward. So just before lockdown, Third Sector Leaders was working with the council to set up community anchors. These were locally trusted third sector organisations in primary care networks. And our thinking was that by having a community anchor in each primary care network, we would better link health and social care activity in the third sector with the primary care networks. And then we went into COVID, and very quickly these anchors switched their role to being COVID response. So the anchors supported the local mutual aid groups. They helped them with practical issues, such as supporting volunteers, ID for volunteers, safeguarding issues, and were there really at the end of the phone for all these people that wanted to help in their communities and were wondering the best way of how to do it. We estimate from the responses from the anchors that at the height of COVID, they were supporting well over 2,000 people every week across Kirklees. We worked very closely with the council's community response hubs. So the council did a triage system. Council staff worked with those residents that needed higher level support and passed on the other requests to the anchors. In addition to the requests that came through the community hubs, a lot of people went directly to the mutual aid groups, community groups, and a lot of requests were coming through the schools that were still open. I think we'll move on to the next slide. So I think the real positives from COVID for us were the development of this anchor model. And as we move on, the community anchors will be going back to the role that we first set them up to do, to work with social prescribing link workers in the PCNs and to really try and bring the community together with the PCNs. But what we have seen really is how people locally have come together to find local solutions to need in their communities. And I think the big challenge for us is how do we build on that? We've got this real enthusiasm for community action. I think we've demonstrated how resourced, locally trusted organisations can make a real difference in communities. And I think going forward, some of the big issues that we face in Kirklees, as in other areas, around healthy lifestyles, mental health, social isolation, a lot of the solutions to these issues really lie in working with communities, in working with groups of people coming together to find local solutions. And I think we can see this in the council's move to place-based working and in the councillors that are taking a lead on mental health in their communities. The community anchors in this current phase are dealing with new needs. I think food is becoming less important, but mental health issues are really coming to the fore. There's a lot of benefits advice as people lose their jobs, as the furlough scheme comes to an end, that are being dealt with. But one of the biggest challenges for us as third sector leaders is making sure that these third sector organisations and community groups are still going to be there in a very challenging economic climate. We recently participated with colleagues across West Yorkshire in a sector resilience survey, and early indications from that had some quite horrific headlines, really, that 22% of groups weren't sure that they'd still be here in 3 months, and that 60% of groups were uncertain about their future after 6 months. So as third sector leaders, we're going to be working with the council to maximise external funding into the sector to make sure really that we do have strong, well-resourced third sector organisations that can be working in local communities for COVID and for other big issues that those communities will be facing. Thank you.
Thank you very much, Val. That's really good. And last but not least, Ian Holmes from West Yorkshire Health and Care Partnership Board.
Hi everyone, thanks Chair. Yes, so my name's Ian Holmes. I'm a director for the West Yorkshire and Harrogate Health and Care Partnership, and going to give a bit of an overview about the work that we've been doing and the next steps as an ICS to support places in their responses. I guess the first point to make is that the ICS is a partnership, so we don't have a formal role within the command and control chain that most organisations who presented here have been describing. I guess what we've learned though and what's clear is that an effective response on COVID-19 requires really strong system working and collaboration, both within the place that colleagues have been describing, but also across West Yorkshire and Harrogate. I'd echo the points that most of the colleagues have made about this being a powerful accelerant for stronger partnership working. And I guess, you know, it's been a tragic event, hasn't it? But one of the positives that we can take from it is that it's galvanised some of those partnerships and some of that close partnership working, which has been a positive. So like most partnerships and most organisations, we have refocused and reprioritised the way that we work in response to the pandemic. You'll remember as a partnership, we've got 3 tests for when we work at West Yorkshire and Harrogate level, recognising that West Yorkshire is the servant of place, not its boss. Is it a scale issue? So the things that we need to work together because, you know, for critical mass, you need to work across place boundaries. Is it an opportunity to share good practice? So can we use the partnership as a way of getting some of that good practice, the awareness raised and some of that stuff shared? And are there any really complex issues that putting our heads together on might give us a better chance of getting a good outcome? And you know, as we've gone through this, there's an awful lot of stuff that fits into those 3 categories, I think it's fair to say. So we've reshaped our work in that way. The other thing it says that our partnership board met on Tuesday, and we had a really good discussion that involved quite a number of folk from this conversation this afternoon. So if you want more detail, more information, it's all live streamed and the papers are there on our website. And the other thing I said about that conversation is that we, just before lockdown happened, I suppose, we published our 5-year strategy. And this was a document that we'd spent quite a lot of last year working and engaging on. And one of the, you know, and the 10 big ambitions in that strategy are probably more important now than they were when we wrote them. So it's things like working together to tackle inequalities, looking at how we support people with cancer by diagnosing their conditions more quickly, how we support Black, Asian, minority, ethnic staff, how we support people with mental health conditions and reduce the rates of suicide in the patch, and so on and so forth. So in doing this, we need to be true to the ambitions that we agreed as a partnership through last year and early this year. When we talk about the COVID response, we talk about it in sort of these 4 phases on this slide, really. So the first one was the responding to the initial kind of surge in demand and surge in cases from COVID, and how we ensure that there's sufficient critical care and acute care capacity to deal with that. We then moved into a period where there was more stabilisation, I suppose, and we moved to a case where the cases weren't rising as quickly. In the conversation about how you begin to sort of restore services in that context. We're then moving into phase 3, which is almost a continuation of phase 2, which is between now and the rest of the year, which is how we work to support people, how we work to start tackling some of the inequalities that have been described, and how we continue to support people working in health and care during a period when COVID is still going to be with us and still present, and during a period when the weather is likely to deteriorate compared to what we've had recently. And that's really importantly. And then the 4th phase is moving into next year. So if you can flick the slides on. And I'll just talk a little bit about the priorities that we've established as a partnership for that phase 2 and phase 3. Sorry, can you go back one, Phil? Yeah, so we've got 6 priorities in that phase 2. The first one is continuing to provide critical and urgent care for people who've got or have had COVID-19, including their recovery and rehabilitation. The second one is around providing essential health and care services for people who don't have COVID but who continue to need care. That's a big issue, an increasing issue, doing quite a lot of comms around that. The work that we're doing to support people who are shielded and other vulnerable groups. Fourthly, the work that we're doing to keep health and care colleagues safe and well. We've had a significant refocusing of our work in the last 2 or 3 months around working at West Yorkshire and Harrogate level to support the response on PPE and testing. That's been really important. We've also been doing work around sort of sharing good practice around staff support and staff wellbeing proposals, so that's been important too. Fifthly, and really important, and it's been touched on a bit today, is there's a lot about this disease that we're starting to understand, particularly around the direct impacts on older people, on males, and on Black, Asian, minority ethnic groups. There's quite a lot that we still don't understand, particularly in terms of those longer term and indirect impacts. And our public health colleagues across West Yorkshire have been working together on some of those things alongside increasingly the university sector, including Huddersfield University, to really start to build a deeper understanding of those implications, so that we can then apply that thinking to how we respond. And then finally, the work that we're doing to coordinate our sort of reset to the new normal, to use that terminology. Next slide, thanks. So the approach that we're taking to, I'll cover this quite quickly, I'm conscious of the time. We start off with these principles on most things that we do at West Yorkshire and Harrogate level, and the approach that we're taking for phase 2 and phase 3 is described on the right-hand side of that table. Just to pick out a few of those points, it's really important that the approach is going to be outcomes focused. There's a lot of talk about returning activity to previous levels. I think we need to start with people and outcomes, and we need to build on the population health management techniques that we've developed recently and apply those to this context. Secondly, this needs to be a multi-agency cross-system response across the partnership, and it needs to build in wider economic recovery. You know, the importance of health and care and that economic recovery and vice versa is going to be essential in the next phase, and we had a good conversation about that in the partnership board on Tuesday, led by Councillor Hinchcliffe from Bradford. We'll use our existing programme governance and ways of working to take this forward, recognising that we'll need to be nimble and that we'll need to adopt new priorities, like I mentioned, on PPE and testing. Fourthly, and this is really important too, we'll work together on the analysis of the issues at West Yorkshire and Harrogate level. We need to build as good a collective understanding of the short-term, long-term, direct and indirect impacts of this disease that we can do. Bringing together public health colleagues, analytical teams, universities will be critical for that. And finally, subsidiarity principles apply, as important here as ever. We know that the way that the virus is impacting on different communities locally in terms of the spread, in terms of the impacts, varies in each of the places in West Yorkshire and Harrogate, and that's why the locally led West Yorkshire and Harrogate supported approach is really important. Next slide. So some of the themes today that we've had coming out of the conversations around this, and building on the conversation around partnership board last Tuesday, just emphasising the point around an approach that's sensitive to local people, local communities. Working in partnership with healthwatch to understand those needs is really important. Working in partnership with VCS organisations is really important. I've mentioned the point around we need to better understand the longer term consequences and impacts of this. Thirdly, and this has been touched on a bit, we're not out of the woods yet. I don't think anyone would think we are, but having a plan is resilient to secondary spikes, localised spikes, having trigger mechanisms and escalation points that work across systems is really, really important, particularly when you're thinking about acute capacity and critical care capacity. Looking across Yorks and Humber around some of those critical care capacity needs connected to the Nightingale Centre is going to be really important. fourthly, huge emphasis on test and trace, getting that working for this whole next phase to be successful, so that we're not in periods of lockdown, off lockdown, on lockdown, off lockdown, etc. Fifthly, significant issues that all places are raising around vaccine, child and immunisations, and some of the kind of the fake news, I suppose, around vaccinims is quite concerning at the minute. And thinking about some of the comms and messaging around that's going to be really, really important, and that's potentially something we could look at West Yorkshire Level 2. And finally, and you've all said this previously, is that there's been a staggering level of innovation that's been taking place. We need mechanisms to make sure that that is sustained, into the next period. So I'll pause there, Councillor Kendrick. I'm conscious that I've probably taken more than my 5 minutes.
Thank you very much, Ian. That's really useful. Can we just, before we move on? Oh, I've got a lot of feedback. Can we move on to the questions that have been raised, Phil?
Yeah. So I think there are two main areas that questions came up around. One was about the testing. So just to clarify some points that were made, and Councillor Ollerton's helpfully contributed the answer to several of these, but I noticed now he's unfortunately had to go to another meeting, so I'll try.
Right. You joined again, I think.
Well, I am still here.
Oh yeah, you're back. Sorry, I just saw the one saying you'd left. Apologies, Steve. So there was a question about when patient testing prior to discharge began, and Steve said, I'm paraphrasing you, Steve, 2 weeks ago, and that means that now people are tested prior to discharge, but they're actually then isolated. If they're discharged into a care home, they're isolated in their room in a care home for 7 days, awaiting the outcome of the test. And obviously then if they're found to be positive, they're treated appropriately. And the isolation's extended to 14 days. And I think Ian Currell mentioned on the CCG element about all the different support now there is for care homes, which has been hugely scaled up over the last few weeks. So that was, I think, dealt with the testing question, unless there's anybody who asked one of the questions has got another.
No, I think Councillor Zaman's point is different from what you've just answered. About, is there any follow-up after the discharge of a patient if they tested positive?
Yes, I think we've dealt with the what happens if they're discharged into a care home. I don't know if anybody else wants to contribute around people who are discharged to other settings if they're positive.
I mean, I can come in if you like, yeah.
Mm-hmm.
I mean, to be honest, it defers to the GP and obviously other people involved in the care home work. I mean, obviously Locala do an awful lot of work in reach work into the care homes at the moment. But if I have a patient that's coming out and is then found to be positive, I mean, that doesn't mean we necessarily have to do anything different because the chances are that they've been positive for a while anyway, and they wouldn't have been discharged if they were medically unstable. So in some ways, it's more useful information rather than us actually having to do anything different. And clearly, the care home have to respond differently. They have to bury a nurse and keep that patient away from other residents. But from a medical point of view, I mean, I haven't actually had to do anything particularly different just because they've been discharged and found to be COVID positive, because as I say, they're generally medically stable anyway.
Councillor Zaman, I don't know if you want to come back about that.
No, that's fine. In terms, it was more about, if they are positive, and then who would look after them as aftercare. But they've answered that. Thank you.
Okay, thank you very much. Does that cover any of the questions? I'm just
there was another question which Helen framed that did seem to link very well into the last point on Ian's slides, which was basically about, so what have we learned and how do we draw that out and have a consistent shared view? So clearly issues about public voice in that, but particularly from the point of view of, I think it seemed to be quite well articulated on Tim's slide from Swift about stop, restart, let go, adopt or adapt, which might be a helpful framework for us to think about this, to say. So.
Phil, if could I just come in on that one quickly? So I think we are doing work to try and capture that at West Yorkshire and Harrogate level, and Joe Farn is leading that. There's a link to a little questionnaire that I can share if that's helpful. I think the trick for us is how we do more than just come up with a nice set of case studies that sit on a shelf. It's how you actually then build that into your future change programs, really, which is something that we're working on with the Yorkshire and Humber Academic Health Science Network. I think that framework, the 4-box framework that Tim was describing, is exactly what we're using. So it's consistent there. I think one of the things we need to be careful around this area is, making sure that we're building in the voice of communities. So most people in the service are saying the digital innovation has been fantastic. What Helen told us on Tuesday is that some of the views from people using the service is a bit more mixed. So we need to just be mindful of that.
Thank you. Okay, can I just say, just thank everybody who's spoken and provided us with information this afternoon. I don't know about other colleagues, but I'm fairly stunned by what's been demonstrated, the resilience and innovation that's arisen from these really difficult and sad times, and the flexibility of staff, but incredibly the speed that organisations have been able to change and move forward, and the cooperation. I have to ask the board now to consider the recommendations at the end of this report. The first point about recognising the excellent work done by staff across the range of organisations and its impact in Kirklees, that the board recognises the vision, outcomes and principles set out in the health and wellbeing strategy, and that the health and wellbeing plan is still valid, and that Kirklees Integrated Commissioning Provider Board review the health and wellbeing plan and present an updated version to a future health and wellbeing board for approval. I'm hoping that everybody is happy about to accept those recommendations. Can I suggest, if you sit still, I'll take that as approval. If you press the little hand thing and you're objecting, I'll know that and come back to you. But are we all in general happy with those recommendations? Yeah, fine. Can I just say once again, thank you so much for the contributions that people have given today. That's been absolutely essential in updating us. And just to say that we have our next meeting, which will be held on the 16th of July. So thank you very much once again. Bye-bye.